Okay, everyone, so we begin where we ended with part one. This is now part two of basic transfers. We have just completed a brief discussion of a transfer with a transfer board. So now we're going to go and discuss uh, squat pivot and stand pivot transfers. So this first area is called seated transfer without a transfer board. And so this is basically when the patient is able to bear some weight, is able to assist, and is able to move from one surface to another without the assist of a transfer board. So as you see the steps here, the patient's basically leaning their body weight forward, and so that as they press down with their legs using their glutes and quads, they raise their ischial tubes off the surface, uh, pivot or shift over to the other surface and sit down. A lot of this will make much more sense once you're able to see it in the lab setting on Monday. So the type of assistance we want to give in this point or during these transfers. So this is a patient who still needs some help, is not able to do it by themselves, but is able to assist. And so in general, as we stand in front of the patient, that way, if they're going to fall in this situation, it's going to be forward out of the chair. Their wheelchair, we'll say, is almost parallel to the surface that they're transferring to, maybe 30 degrees offset. And so basically, as they lean forward, put their body weight through their legs and lift their hips up, we are there to help. Sometimes we put both hands at their hips or under their ischial tuberosities to help raise them up. Sometimes we can use the sides of their pants if they're wearing those and help them to get the assist they need to lift the remainder of their body weight. So a pivot transfer, a patient has no weight bearing restrictions on at least one lower extremity. So this is something that could be used with a patient who's partial weight bearing on one lower extremity, but they have the ability to weight bear through another lower extremity, and they have the strength to raise their body weight up off the surface on which they're sitting. They have to have that cognition intact so they can follow directions, they can respond to our cues. And so basically, a pivot transfer, the patient, instead of standing all the way up, they're going to remain in a partial sort of seated position and really raise their hips up just enough to clear the surface on which they're sitting, and then pivot or rotate so that their hips go to the new surface. So as we set all of this up, we want to make sure that obviously if they're in a wheelchair, that's locked. If they're going to a hospital bed, those wheels are locked. Make sure there's nothing in the way inhibiting their movement. For example, the leg rests of the wheelchair often need to either be removed or at least swung out of the way. We want them to have something on their feet so to avoid slipping. So if they can wear shoes or at least the socks in the hospital with the non-skid protection on the bottom. And so we will demonstrate this in lab, but basically we want to get the patient's hips to the front edge of the wheelchair, and therefore as they push down with their legs with their body weight shifted forward, it will result in their hips coming up out of the chair. If a patient is seated all the way in the back of the chair, leaning back, and they push down with their legs, they're just going to push themselves backwards. So therefore, we need to begin by having them forward in the chair. So when they push down, the result will be that their hips come up out of the chair. So we'll demonstrate this in lab. So we want to make sure that their feet, some of the common errors that patients will make is they will try to start the transfer when they're sitting in the back of the wheelchair. So we need to get their hips forward to the front of the chair, and their knees need to be flexed sufficiently so that their feet are below them. So once again, so that when they push back or push down with their feet, the end result will be their body weight going up instead of back. And usually shoulder width apart, and sometimes if there's weight restrictions, let's say their right lower extremity it has partial weight bearing, then we would be transferring towards their left side, and where they can put all the weight on that left lower extremity to help offset their weight. We want trunk flexion. We want them to, often you'll hear nose over your toes. We want to have the patient lean forward in the chair. So now their center of mass is coming over their base of support. And for some patients, this causes apprehension and fear. That's why we as the therapist will position ourselves right in front of the patient to reassure them that they're not going to fall forward, and that all of those positioning cues are necessary so that they can use what strength they have to help them with the transfer. So we'll have a gait belt, and obviously that in sometimes in all cases, depending on the policies of the facility in which you're working and depending on the needs of the patients, a gait belt is always a good idea. It gives us something a way to provide support. So we want to make sure that the patient is not grabbing the therapist around the neck, that instead they are hopefully pushing down off the armrests of the chair to, if they can use their arms to help. And we want to make sure that sometimes patients will be apprehensive and fearful, and that white knuckle grip can be evidence that they are worried about what's about to happen. And if that's the case, then we need to be very careful about that. Sorry, I inadvertently skipped a couple slides. Okay, so we want to be in front of the patient. We want to be in sort of an athletic type stance where we have a wide base of support. We're flexed at the hips and knees. We've lowered our center of gravity. Sometimes we have a staggered foot position so that one foot is forward, one is back, anticipating what our finishing position is going to be at the end of the transfer. Once again, we'll demonstrate this in lab, but we want to have a hold of the gait belt on each side of the patient with that underhand or palm up grip. At times, it is necessary to block the knees of our patient. So as we are standing in front of them, we will use our knees as a way to inhibit any forward sliding motion. So their knees aren't going to come forward anymore. So when they push down, once again, their hips are going to elevate. Sometimes there's just one lower extremity that's weak, so we'll just block one knee. Again, we'll demonstrate all of this in lab. Sometimes we will have both of our knees on both of the patient's knees. This is also illustrated in the videos you have access to through your textbook, and that is a way that we can, again, kind of get a rocking pivot type of motion where our body weight goes back and down and their body weight comes forward and up, and that helps to get the motion beginning that we need to complete the transfer. So now a stand pivot transfer is for a higher level, more independent, stronger, better balanced patient. It should be intuitive and logical, but for a patient who's not strong enough to stand all the way up, they need to use the squat pivot. The stand pivot is one where we can have the patient stand up. We can take a break there. We're standing right in front of them, let them get their bearings, make sure they're not dizzy, and then they can take a couple of little steps, rotating so that they're oriented so that they can sit down on their finishing surface. When we do a squat pivot transfer, it's all one motion. Once we're started, we've got their body weight coming forward, their hips coming out of the chair, and in one fluid motion, we're going to rotate and sit them down in their ending surface. For a stand pivot, we can do that sequentially, and this can be obviously the next step towards independence, right? Where a patient's going to be able to stand up on their own, maybe with their walker in front of them, take some baby steps to rotate 90 degrees, and then lower themselves down to their position. Excuse me. Okay, so in general here, as the patient is standing up, we're in front of the patient. We sometimes block the knees if needed. The patient leans forward as we lean back, and the patient starts to stand up. With any of these transfers, if something begins to go wrong, like a patient's foot slips or their hand comes off the armrest or we lose our balance, always safer to just abort mission and set the patient back down, regroup, and try again, as opposed to at all costs continuing with the transfer. Sometimes if something's going wrong, if a patient's losing their balance or getting fearful, it's better to stop and start over. So with a stand pivot transfer, we're going to be all the way up. It can be one motion if needed, or it can be, as I said, a series of small movements. We need to get them. Often we will give the cue that we want you to be rotated so you can feel the wheelchair or the chair or the bed with the backs of your legs, both of your legs before you sit down. That avoids the tendency some patients have when they're getting tired or scared to just sit down before they are correctly positioned. So with that stand pivot, we have the ability to do it all quickly in one motion or to break it down and do small motions. And so once they're standing and they've turned sufficiently so their back is to their finishing surface, instead of just plopping down, we want them to reach back and grab a hold of the armrest. Obviously, this is going to be more stable, more secure, and then they can help themselves to lower down. So very often with patients, maybe at the end of a walk or with a transfer, if they're very fatigued, they're going to want very much to just land in that chair, which can be very dangerous. So we always will be cueing them to slow down, take a break, and use their arms to lower themselves down into the seated position. So another area that we want to discuss is seated repositioning. For a lot of patients who spend a great amount of time in wheelchairs, they will gradually slide, their hips will slide forward, and they'll end up in a slumped, poor sitting posture. And so often it is necessary to reposition them in the chair. And this mimics in many ways these transfers that we're doing. We will be doing the same types of cues where we're going to have them lean forward, get the weight on through their legs, and then as they push down with their legs, then they can scoot their hips back to the back of the chair. And so we'll demonstrate this in class as well. So once we're all done with our transfer, let's say they're back in their wheelchair or in their bed or in their bedside chair, we always want to make sure this is often what is happening at the end of a treatment, and we want to make sure that they are secure, safe, and comfortable. And so very often we will make sure that we put the armrest back on the wheelchair, swing the leg rest into place, get their feet positioned on the foot pedals, give them their call bell, their TV remote, whatever they need depending on the circumstance before we leave them. So squat pivot versus stand pivot transfers. Everything is similar as far as foot position and chair position. Our hand placements will be different. Basically, with a squat pivot transfer, we are prepared to provide much more assistance coming from us. And so we're going to have a much more secure grip on the gait belt. And we're going to be, because the squat pivot transfer is going to happen in one fluid motion, there's a lot more preparation that needs to happen. Once we've started and got their inertia and their body weight moving, we want to be able to be prepared to complete that motion in one fluid movement. And so you can look in this table 11-1 in your textbook to look at the differences. So once again, we talked through some of the elements of a squat pivot transfer. And so this is just to review both of these two types of transfers before we conclude. A squat pivot transfer is for a lower level, weaker patient, and we are going to be doing more of the work ourselves with this, and we're going to make sure that we are controlling their body weight, getting their weight to shift forward so that we can get their hips to come up off the surface. Then we're going to rotate them and then lower them in a controlled way into their seating surface. For a stand pivot transfer, the patient is a higher level patient with more ability, greater balance, greater strength. And so our role is going to be a little bit less from a physical standpoint. We're going to be assisting them to come to a standing position and then either in one motion rotate and sit down or slowly sequentially rotate before they sit. Just a couple of comments about assistive devices. Really the first two on the left, the pivot disc and the pivot pole, are examples of things you likely will not and should not use. They do exist, so we include that. But very often a walker is used as part of these transfers, which will facilitate future independence. Once we are done and the patient's on their own, often they'll be using a walker for their own independence. And that includes our basic transfers. We'll see you in lab. Thanks.